The topic for today is how to manage abnormal growths that develop on the woman's uterus. Okay, so as a way of introduction, these growths, also known as uterine fibroids, they are the most common benign tumor in women of reproductive age. And we know that the reproductive age is from 14 years to 49 years. And then these growths are also clinically significant in about a third of the women. And they cause significant morbidity and are also a major reason for hysterectomies. That's the removal of the uterus. Okay. So they are the most common solid tumor in the reproductive age. Around 20 to 25% of all women have these growths. And then for clinical presentation, there is a big range from asymptomatic. Asymptomatic is where the patient doesn't have any symptoms, to menorrhagia. Menorrhagia is where you have lots of heavy bleeding during the menses. Pelvic pain and pain cramping during the periods. That's also very common. It's also known as dysmenorrhea. And then we have pressure symptoms on adjacent pelvic organs. We know that the fibroids, because they have a mass, you find they compress the urinary bladder, they compress the rectum, and you can get symptoms arising. We also have recurrent miscarriages. That is loss of pregnancies due to the uterine fibroids. And then also during labor, during pregnancy, they can also cause obstructed labor or even increased bleeding, known as PPH. These fibroids or these growths, abnormal growths on the woman's uterus, rarely appear before onset of periods, and usually also they regress naturally after menopause. So we have a diagram showing how the fibroids can present, or the abnormal growths can present. We have some that can sit right in the center of the uterus. These are called submucosal fibroids, the one dead in the center. And then we have those that are formed on the uterine walls. And these are called intramural fibroids. And then we have pedunculated or subserosal. They are hanging outside of the wall of the uterus. These are called pedunculated fibroids. Okay, so fibroids usually can be single or multiple, and then they tend to be firm, round, or oval, composed of smooth muscle bundles in what we call like a whore-like pattern. And then sometimes they can occur in unusual places, for example, the cervix or the broad ligament. When you look at them under the microscope, you find non-striated, basically muscle fibers arranged in bundles and running in different directions. Okay, so now symptoms. We are going to go over the symptoms in depth. So we have the abnormal uterine bleeding. This is usually presents as either very heavy menstrual bleeding or intermenstrual bleeding. And then normally you find during menses, a woman might use 3 to 4 pads in a day, but now with uterine fibroids, for some women, they even use a whole pack of 10 pads in a day, and even the heavy pads, and sometimes there is still bleeding even through the pads, what is commonly known as flooding. And sometimes also we get heavy bleeding manifesting as clots. Normally the normal menses should not have clots, but now for heavy bleeding or abnormal uterine bleeding, you have passage of clots, and then also bleeding in between the menses. And then also we have a very common presentation of pain during the periods. That's known as dysmenorrhea, and sometimes also pain during intercourse, known as dyspareunia. Sometimes the pain can also be as a result of what we call torsion. Torsion is that the fibroid twists, especially the pedunculated fibroids, they twist on its axis, and this causes very severe pain. And then also we have a phenomenon known as degeneration of the uterine fibroids. These ones, because of the rapid growth of the fibroids, they outstrip or they outgrow their blood supply. And then you have severe pain due to degeneration. And then we have talked of the pressure symptoms. This mass at the uterus, you find it compressing the urinary bladder, and that gives you urinary frequency and obstruction of urine, and also compressing the rectum, giving you constipation. And then commonly also women would feel a mass on their tummy, and for some it's very severe. Actually, they might think it's a pregnancy, but it's not a pregnancy, it's fibroid. And then we have infertility, couples who have been trying to conceive, but they have not been successful. Okay. So we have said menorrhagia is the most common. Patients have heavy menses leading to anemia, and it's due to an increased surface area where the endometrium is stressed and forms a very large surface area when the menses come around. Pain you have described due to the period pain, dysmenorrhea or torsion or degeneration, and this degeneration commonly occurs in pregnancy. Infertility is also a common presenting feature of these uterine fibroids, and we find that up to 40 to 60% of our patients conceive after myomectomy. The likely pathogenesis of this infertility is the mass effect of the fibroid may act like an intrauterine device, and hence interfering with distorting the uterine anatomy, and may interfere with implantation, among other complications. And then in pregnancy, we have described that number one, in early pregnancy, there is a risk of miscarriage due to the uterine fibroids. And then also we have severe pain in pregnancy. Commonly, we have red degeneration, where the fibroid is rapidly growing and it's outstripping or outgrowing its blood supply. And some portions of that fibroid begin to die off, also known as red degeneration. PPH is common, that is postpartum hemorrhage, that is excessive bleeding after delivery, because the fibroid will prevent the proper contraction of that uterus. And then we also have malpresentation. Normally the baby should present with the head or cephalic presentation. Due to the uterine fibroids, you'd find maybe it's the buttocks presenting or it's the arm presenting. Rarely we have polycythemia, and that is increased red cell mass or count, or hypercalcemia, that's increased calcium levels in the serum. So what are the risk factors? There are many risk factors that have been identified with the causation of fibroids, and we are going to mention some of them. Number one is early menarche, or the time when the lady starts receiving her menses. The earlier we find that the earlier the menses start, the more likely the patient might have fibroids later on in the course of her life. We have nulliparity, that is a risk factor associated with increased risk of uterine fibroids. These are ladies, women who have not carried a pregnancy. And then the fibroids are more common as we go towards the late reproductive years, the third and fourth decade of life. And then obesity. Obesity has been associated with an increased risk of uterine fibroids. And then we have the African American ethnicity, or Africans, let's just say Africans in general. We are more predisposed to having uterine fibroids. We have risk of use of tamoxifen. This is medication used for breast cancer. It's associated with increased risk of fibroids. And then there are factors which are protective. We'll mention a few. Number one, we have said menopause. Once a woman reaches the age of menopause, there is less risk of developing uterine fibroids. And then increase in parity has been known to be protective. The more a woman has carried a pregnancy and delivered, the less the risk of developing uterine fibroids. We have a surprising factor that smoking is associated with this decreased risk of uterine fibroids, though for sure we don't advocate for smoking because of the many other side effects that are associated with smoking. Okay. So yeah, early menarche, we have elaborated on these points, and the theory is that there is an increased number of cell divisions of the myometrium during the reproductive age, and activity of the myometrium the earlier the menses start. Okay. And then also due to the increased proliferation of the myometrium, there is increased chance of mutation in genes controlling the myometrium proliferation, and that's an increased risk of uterine fibroids. Parity, we have said that the more a woman has carried pregnancy, the less the incidence of uterine fibroids. So we find that pregnancy reduces time of exposure to unopposed estrogens. And then age, you have also mentioned that the risk of new fibroids increases in the late reproductive years, that is the usually third decade or the fourth decade. We've said obesity increases risk of uterine fibroids due to conversion of some steroids that are produced by what we call the adrenal gland to estrogen by the fat tissues. This now the steroids converted to estrogen, which acts on the uterus fibroid, on the fibroid, leading to increased formation of uterine fibroids. Okay. And then diet is also a very common cause of uterine fibroids. We have moderate association between the risk of fibroids and consumption of beef. Basically, we see association between consumption of these saturated fats, like those found in beef, ham, while intake in green leafy vegetables, this is found to be protective. And then of note that vegetarians have 20 to up to 20% less plasma estrogen levels, and even up to decreased incidence of uterine fibroids for the ladies, or for the population that is vegetarian. We have mentioned that it's more common in the Black population. more common in the black population, less common in the Asian population, and least common in the Caucasian population. This might be due to several factors, including genetic and also circulating hormones, and especially the estrogen. Smoking is we say paradoxically has reduced risk of fibroids, but we don't recommend smoking at all. Okay. We do have genetic predisposition to uterine fibroids. Number one, we find that there is a higher ethnic predisposition among Blacks. And then there are studies that we have done in the medical community, like the fibroids are more common in identical twins than in the non-identical twins. So we have a genetic factor involved. And then what we also call familial aggregation, that is clusters of fibroids, especially among first-degree relatives of women. Like that's like the mother is affected, her sisters are affected, maybe the maternal aunts, and also her daughters. So formation of fibroids, it's a very complex interplay between genetic factors, between hormonal factors, and especially estrogen and progesterone, and then the stimulation of the muscle and formation of these masses. So what happens if a patient presents with any of the history that you have listed? That includes the heavy menstrual bleeding, there might be a mass when you palpate, she might be anemic. So as a bare minimum, as clinicians, we do hemogram. This is your blood count. We are checking the blood level. And then also commonly we do imaging. The most common, the most prevalent is the uterine, the pelvic ultrasound. We also have additional imaging techniques. This includes the saline hysteronogram. Sometimes in some centers, or depending on the indication, we also do pelvic or abdominopelvic MRI, and also hysteroscopy can be also used to visualize the uterine fibroids. So as a clinician, before we start off our patients on management, there are factors that we do consider. We consider the age of this patient, and age has a bearing on the suitability on the management option adopted. We consider the severity of the symptoms. The more severe the symptoms, the more they may need your intervention. We consider fertility, whether this lady has had children or is even in like they might be single, still in school, pursuing their education. So management will differ, as opposed to maybe a couple who have been married for 2-3 years and they have not conceived. We consider comorbidities. These are other conditions that may be associated, and other medical conditions that this patient might have. We consider previous interventions, whether this patient has had any intervention in the past. We consider the number of the fibroids noted, and then also we consider the size of these fibroids, and then their location and the patient's wish. The patient's wish is also paramount for the good management of uterine fibroids. So we have what we call asymptomatic uterine fibroids. It is estimated that at least 50% of uterine fibroids are asymptomatic, and these fibroids usually are found as either incidental findings, either the woman was doing an abdominal scan due to something else, but we discover that they have uterine fibroids. And then it's the role of us, the clinicians, the doctors seeing these patients, to allay anxiety, that you reassure the patient that usually they have anxieties, whether there is any possibility of the fibroids being cancerous. We need to reassure them that up to over 99%, they are benign or non-cancerous growths. And also another worry the patients have is whether they need a hysterectomy, that's the removal of the uterus, and whether the fibroids will compromise fertility and pregnancy, or the pregnancy and the pregnancy outcomes. And then also whether these fibroids are likely to grow, and if there is any therapy that is known to stop them from growing. And then if watching and waiting will cause any harm, so we need to discuss comprehensively. So the first option that we have for management is medical therapy. This is used when the symptoms are not severe, and as a standalone treatment is used for temporary relief of symptoms for short periods. For example, if a woman is perimenopausal, almost approaching menopause, you might just decide to give her medical treatment until she gets to menopause. We also use medical treatment where the patient is not suitable for surgery. And we do have cases, for example, a patient with coexisting cancer, we are not inclined to rush to theater to remove these fibroids. And then also medical therapy can also be used preoperatively to reduce the sizes of the fibroids and to control bleeding and to improve the hemoglobin levels. So what are the options available for the management of these fibroids? Medical options. We have, commonly we give tranexamic acid. Tranexamic acid is given to primarily control bleeding. We have NSAIDs. These are medications like Brufen, Olfen, diclofenac. We have combined estrogen progesterone pills, OCPs. These are also commonly used. And then we also give the progestins, like the long-acting progestins, like the Mirena intra-uterine device. We also have GnRH agonists and antagonists, and also other medications given include anti-progesterones and progesterone receptor modulators. And then also we have estrogen receptor or selective estrogen receptor modulators. So we have covered others are still experimental, like aromatase inhibitors, not found to have a very definite role. So we'll go in brief over some of these medical treatments. Tranexamic acid, very commonly given. This one of note does not shrink the fibroid. Primarily, it's given to reduce the heavy bleeding or the abnormal uterine bleeding. It works as an anti-fibrinolytic agent, and it inhibits activation of the clotting factors, that is the plasminogen to plasmin, which helps to stop the bleeding. Can be given up to 1 gram, up to 1 gram 4 times daily, but commonly we give 1 tablet, that is 500 milligrams, 8 hourly. Okay. And then we have NSAIDs. NSAIDs, these are medications like Brufen, diclofenac. They are given for pain control. They also help in, especially in combination with the tranexamic acid, they help in also reducing bleeding. We have the combined pill. Combined pill helps in works by causing endometrial atrophy, and this helps to control both bleeding and pain. And this can be taken either as the normal pill that we give our patients, or even the patch, commonly known as the EVRA patch. The other group of medication is known as GnRH agonists. This cause central inhibition of the reproductive hormones, or medically central inhibition of the hypothalamo-pituitary axis. This ultimately, when given, they suppress production of the reproductive hormones, that is the estrogen and the progesterone. They create what we call as hypogonadic, hypoestrogenic environment. This is decreased estrogen production from the ovaries. And this can be commonly administered through an injection, either a monthly injection or once every 3-month injection, or even they can be administered vaginally. They are noted to improve the heavy menstrual bleeding or the menorrhagia, and even inducing amenorrhea in some women, depending on the duration of use. And they facilitate to a great extent the restoration of hemoglobin levels. Though they do have disadvantages, they lead to a reduction in bone mineral density, and also commonly lead to development of menopause type symptoms of estrogen deficiency. These are symptoms like flushing, hot flashes, vaginal dryness, and the osteoporosis. And then also of note, they are quite expensive, and usually we can't use them for long. We use them for maximum of 6 months. We have another group of medication known as GnRH antagonists. This reversibly inhibit the brain axis or the hypopituitary ovarian axis. They immediately suppress the pituitary reproductive hormones. Though they are short acting, that daily dosing is required. We have another group called the selective estrogen receptor modulators. These are non-steroidal estrogen receptor medications that act that stimulate estrogen in some tissues while blocking estrogen action in other tissues. An example is raloxifene. This maintains estrogenic activity on the bone, while in the uterus is anti-estrogenic. So in the bone, it won't, this kind of medication won't lead to osteoporosis, but in the uterus, it will inhibit growth of the fibroids. And then they also are known to cause a reduction in the fibroid volume. Side effects of this medication include hot flashes, weight gain, increased appetite, dry skin, and also there's a risk of venous thromboembolism. They're also quite expensive and also not very readily available. Aromatase inhibitors has not been found to be, the evidence for them is not very strong. We have the long-acting progesterone devices, commonly the Mirena. Mirena is an IUCD, intra-uterine device, that is inserted just like the normal coil. And this releases 20 milligrams of levonorgesterol every day. And it has been shown to reduce abnormal uterine bleeding or menorrhagia by up to 94% by the 3rd month after insertion. And mechanism of action, this device, it's a medical device, causes prevention of endometrial proliferation. There is significant reduction in heavy bleeding, but the uterine volume and the myoma volume remains the same for patient on Mirena. And then we have anti-progesterone agents, commonly mifepristone. This is given as a tablet of either 5 milligrams or 10 milligrams per day for a year. This drug has been shown to cause up to a 50% decrease in the uterine volume, and 40 to 7% of patients experience lack of periods or amenorrhea. Side effects include hot flashes, vasomotor symptoms, and endometrial hyperplasia. And then we also have another medication. This is a selective progesterone receptor modulating agent. Acinoprisnil reduces the fibroid volume and symptoms of menorrhagia. However, of note, these medications are still relatively new, so they are quite expensive, and they're also not widely available. And also their use is restricted. Especially because they also have other effects on the body, like they are known to be abortifacient medications, so they are tightly regulated. So we have surgical approaches. We'll mention some of the approaches. We have myomectomy. And of the myomectomy, we have laparoscopic myomectomy. This is the small incision myomectomy. And then this has been found to have similar outcomes between the big cut myomectomy or open myomectomy and the laparoscopic myomectomy. And though it has several advantages: less hospital stay, less pain. We have a hysteroscopic resection of uterine fibroids. These are used for what we commonly term as submucous fibroids, like the ones dead center in the cavity of the uterus. A small telescope is introduced to the cervical canal to inspect and remove fibroids and polyps. And then distended medium, usually normosaline or like glycine, and then these fibroids are chipped off small piece by small piece. Like this one, this is hysteroscopic resection of uterine fibroids. And now this lump here represents the fibroid, and the surgeon, the gynecologist, is resecting this fibroid piece by piece. Complications of hysteroscopic resection include fluid overload, and then also we have electrolyte imbalance, especially with use of fluids without electrolytes. We have a risk of uterine perforation, we have risk of bleeding, we have infection, we have cervical lacerations. And then we have what we commonly known as interventional radiological procedures. This is primarily the UFE. UFE stands for uterine fibroid embolization. And then also we have a new technique also under development or still experimental, not widely available, known as magnetic resonance guided focused ultrasound surgery of the fibroids. So uterine fibroid embolization, this is a uterine sparing procedure. It's available both at Aga Khan Nairobi and Aga Khan Mombasa. And what it entails, a special catheter is introduced through the groin or through the femoral artery. And this catheter is guided under vision all the way to the uterus and the uterine vessels, supplying the blood to the uterus. And then a special dye is injected that blocks the blood supply to the uterine fibroids. And then, this one shows this special dye on the polyvinyl particles being injected in the uterine artery, causing the death of the fibroids. There are some contraindications to use of the uterine fibroid embolization. Any evidence of current or recent infection of the genital tract. This includes infections like pelvic inflammatory disease, PID. And then when the patient is categorical that should refuse to have a hysterectomy under any circumstance, sometimes we do have hysterectomies being done after UFE due to an occasional complication. And then a relative contraindication, usually given for women who might not desire to conceive after that procedure. Or other relative contraindications include coagulopathies, subserous fibroid that will fall off into the abdomen, or immunocompromised patients. Complications of the uterine fibroid embolization, we have immediate complications occurring within the first 30 days and late complications occurring beyond the first 30 days. So the early complications include things like hematoma. We're introducing a catheter through the leg artery called the femoral artery. So you can have arterial thrombosis, sometimes dissection, or an aneurysm that is ballooning. And this is prevented by using a small catheter with minimal manipulation during the uterine fibroid embolization procedure. And then we have what is known as the post-embolic syndrome. This consists of pain, nausea, fever, and flu-like symptoms with raised inflammatory markers and white cell count, commonly managed by giving paracetamol and other analgesics. And almost all patients experience this, but with post-operative care is usually quite well managed. We have risk of urinary tract infection and deep venous thrombosis, known as DVT. We have a persistent vaginal discharge, usually self-limiting, but persistent discharge with pain could mean that the fibroid is being expelled. Sometimes we might need to go back after the UFE. We might need to go back and do a hysteroscopy and remove the submucous fibroid that have been expelled. And then other side effects long-term include amenorrhea, lack of periods, or even premature ovarian failure. And then we have reduced sexual function due to impaired blood supply of up to 12%. And then we have a risk of infection, that is inflammation of the inner lining of the uterus, known as endometritis, in a very small percentage. And then also for these patients, we do cover them with antibiotic cover. And then for the advantages, for the UFE procedure, symptomatic improvement in the rate of menorrhagia in approximately 85% of our patients, especially in the first 12 months. And then reduction in the uterine volume, 40 to 60% within the first 6 months after embolization. We have magnetic MRI guided ultrasound surgery. The principle is similar to focusing the sun's rays with a magnifying glass to burn a hole in a piece of paper. This delivers a focused high energy ultrasound wave into tissue to cause thermocoagulation of the fibroid. Though it has a few contraindications, especially for patients who cannot undergo the MRI procedure, like patients with cardiac pacemaker or with severe claustrophobia or previous abdominal scarring, like from previous abdominal surgery, and also for patients with IUCD, and also very obese patients or pediculated myomas. Some of the complications include skin burn, a burn on the skin, DVT, deep venous thrombosis, or even, unfortunately, sometimes bowel perforation. But it's roughly similar to UFE, not commonly available, and in our setup, not available, but available, especially in the Western world. So commonly, what we have available is the surgery. This can be, we have mentioned laparoscopic myomectomy. We have open myomectomy. And then we have hysteroscopic resection, especially depending on the kind of fibroids that the patient presents with. Like the image shown on the right shows this is a procedure of open myomectomy due to the number one, the main indication is multiple. The uterus, the fibroids are very many, and then they're also quite big. But for each of the modalities, the doctor and the patient will sit down and plan and see which is the most suitable approach for removing these fibroids. And then a common questions that patients have, do fibroids recur after myomectomy? We say that in a patient in the third or fourth decade, 30-year-old to 40-year-olds with more than one fibroid or one myoma surgery, recurrence rate is low, 30 to 40% in 10 years. And by then you have improved their quality of life. They won't have anemia, they won't have the menorrhagia, they won't have the pain. In patients older than 45 years, symptomatic recurrence, that is with heavy bleeding, with pain, is less than 1%, or is actually 1%. This is a reasonable age group for these patients in this age group. And then we have hysterectomy, that is removal of the whole uterus, and it has several indications. That is failure of other previous therapies like myomectomy or even the uterine fibroid embolization. This is also an option for women who have completed childbearing. The woman has 3, 4 children and says, Daktari, I just want this problem resolved, and she has no desire for future childbearing. And then concurrent pathology, like carcinoma in situ or adenomyosis. And also this is why it's important for your doctor to do a pap smear even before planning a removal of uterine fibroids, because there may be other abnormalities like cervical abnormalities, abnormal cells that can lead to cancer. So you may prefer to do a hysterectomy if there are other problems that are found. Adenomyosis also can be picked up that coexists with uterine fibroids. And then adenomyosis, usually the endometrial tissue is found within the muscle, leading to symptoms similar to uterine fibroid symptoms. That is especially pain, severe pain during menses. So we do have indications for even actually removal of the uterus. This is noted to be a definitive treatment with very high levels of satisfaction and no recurrence of the uterine fibroids. So thank you very much. I know it has been a long session. We will allow for questions, a Q&A session. Janet, our moderator, will help us ask the questions which might have been asked in the chat session, and then we'll answer the questions one by one. Thank you very much.
Thank you very much, Dr. Ngugi. That was very deep. So it's time for question and answer. And please raise your hand if you want to ask any questions. There are some questions that have been posted on the chat box, which I'll ask through and then you can answer. So one of them says it's great. She hopes, or they hope to hear something about Nabothian cyst. Maybe if you can talk a bit about Nabothian cyst. And another question has come up asking whether fibroids affect fertility and sex life, and are there chances for the fibroids to recur after treatment? I think this you have already mentioned, but you can repeat it, Dr. Ngugi.
Oh, okay, thank you for those questions. So Nabothian cysts, basically, we say that any woman in the from age 21 or from sexual debut whichever comes earlier. They are recommended to have a pap smear initially annually or every 3 years, especially if the woman has been on good follow-up, and then we have normal pap smear results. These women can do their pap smears once every 3 years. So sometimes during the pap smear procedure, your doctor may mention that they are what we call as Nabothean cysts. These are cysts that are usually seen on the cervix. Either commonly most detected by the speculum procedure and during the procedure of doing the pap smears. And also sometimes rarely they can also be picked up on ultrasound, pelvic ultrasound. So Nabothean cysts, it's like a collection of mucus. A cyst basically it's just a collection of fluid, but this now occurs in the cervix. And then for any patient with an Nabothean cyst, it should we say biopsied. A small piece of it is removed and taken to the lab just to make sure that it's not cancerous. So Nabothean cyst, always biopsy is indicated. This can be done in the office or in theater, and then it's presented to the lab for analysis to make sure that it's not cancerous. We have said that uterine fibroids can affect sexual function due to the mass effect, and it can increase pain during sexual activity, also known as dyspareunia. Janet, just repeat the last bit, the last question.